Perfect. Okay, so let's get started. So this is a presentation on bacterial endocarditis, and we'll go through it. And once again, please ask questions. Please, be as interactive as you want to be. Okay. So this will make more sense at the end if you haven't learned about endocarditis yet, but this is saying not sure if I hit my thumb on something or if splinter hemorrhage is from infective endocarditis. So if you haven't seen this before, keep your eyes out at the end of the presentation. Okay, so we'll start off by going through the case and then go through the physical exam, go through a very thorough differential diagnosis for this patient, an assessment and plan, and then talk about the pathology of the disease at the end. So yeah, actively participate, fill out the SOAP note, and if anything's unclear, just put in the chat or unmute yourself. Okay, I hope everyone has their note in front of them. It looks like Becca dropped a Google form for everyone to pull up. So we have Mr. M. He is a 51-year-old, and when I was interviewing him, he said he had no past medical history at all. He was a healthy guy. Coming into the emergency department with multiple days of fevers, both subjective and objective fevers, chills, progressively worsening shortness of breath, and this was all over the past 4 days. Of note, he was seen in the emergency department 2 days prior for the same complaint, but he ended up leaving against medical advice to use drugs. He also stated that he was having bilateral lower extremity swelling and intermittent chest tightness. After I interviewed him, I went back and looked at his chart, and even though he said he didn't have any medical history, during his last visit in the emergency department, he was actually found to have new onset heart failure. So someone put an ultrasound on his heart, just very quickly, like a bet on ultrasound, and saw that he didn't have any squeeze on his heart, and also his lab showed that he was heart failure, and then additionally he had an ultrasound done and a CT done of his chest that showed that he had bilateral pleural effusions. Those were done because there was concern that he had a pulmonary embolism because of his shortness of breath. So that is when I first met him. Okay. So questions to consider. So what other questions do you all think could be important to ask this patient? You can type it in the chat, unmute yourself, whatever works. Okay, family history of heart issues. I think that's a really good question. It's always good to do a really thorough family history. I really like that one. Other things that I was thinking about that I didn't, what were you doing when the symptoms began? That's a great one. Always trying to elicit what was happening at the beginning. Any past infection, so whether that be like a systemic infection or an organ-based infection. Yep. Personal history, smoking, drinking. Yep. A good social history is always super, super important in these patients, in any patient, really. Great. Good job, everyone. Another question. So this patient mentioned that he uses drugs. Is there any type of question that you think could be helpful to further characterize the patient's drug use? Okay, do symptoms get worse during drug use? How often is he using the drug? Good. What are some ways that people use drugs? There are different ways, right? Yes, IV drug use. Yes, good, good, good. IV drug use. But yes, some people take them orally, some people snort them, some people use them rectally, and then there's IV drug use. So that will come into play a little bit later. And then if someone is coming in with, shortness of breath and some chest pain, what types of things would you really want to pay attention to on physical exam? Mm. And new onset heart failure. Good. So looking at the vitals, taking, yep, a really good set of vitals. Blood pressure. Okay. Yep. We don't want to look at their heart rate, listen to their lung sounds really, really closely in all of their lung fields, right? Anterior and posterior lung fields. Great. Looking at their oxygen levels, also very important. Great job. And then with his new onset diagnosis of heart failure, another thing that I always recommend looking for is just looking at to see the general volume status of the patient. So some people may have some swelling up to their shins or their knees, but then sometimes you'll see people in really bad heart failure who have swelling all the way up to their stomachs or higher, anasarca. So always good to look out for that. Great job. So just like all the things you all hit on, so this patient's vitals, when he first came in, his temperature was 101.4 degrees Fahrenheit. Heart rate was 115. His respiratory rate was 30. Any thoughts on if a 30 respiratory rate is high or low or normal? Yeah, very high, right? We normally breathe about anywhere from 12 to 16 times a minute. 30 is very high. His blood pressure was 110/80. I did some chart review and it seems like he sort of lived around there, more or less. And then his oxygen saturation was 98% on 5 liters of nasal cannula. So the fact that he had 5 liters of nasal cannula on but was still breathing 30 times a minute and he wasn't saturating at 100% room on the oxygen, it was a little bit concerning to me. So when I looked at this patient, he was tired. He was sitting at the stretcher, not normally patients, are laying back. He was really like leaning forward and almost tripoding, not exactly. On the auscultation of his heart, he was tachycardic, but the regular rhythm. And the first time I listened to him, I didn't hear anything, but then I went back and listened to him. And I actually heard a decrescendo diastolic blowing murmur, best heard at the left lower sternal border. Pulmonary, so he had crackles in the base of his lungs, and then also had like very rondorous breathing in the upper airway, so in his upper lung fields. And as I mentioned before, was satting 98% on 5 liters of oxygen and seemed to be having increased work of breathing. So he was only speaking 3 to 4 words before he had to take a breath and take a break. His abdomen was soft, non-tender, non-descendant. His extremities, he had 3+ pitting edema up to his knees bilaterally. His legs seemed like they were the same size to me on gross visualization, so not one leg seemed bigger than the other. And then he also had a negative Hohmann sign. Neurological exam was completely intact. He had 5 out of 5 strength in all extremities, despite being so short of breath. Cranial nerves were intact, and he knew where he was. He was oriented to person, place, and year. And then on skin exam, he had multiple scars and scabs on his bilateral arms, his legs, and the dorsum of bilateral feet. Okay. Let's see, what does decrescendo mean when listening to their breathing? So the decrescendo noise was heard when I was listening to his heart, and that's actually indicative. The specific noise I was hearing is indicative of a certain type of murmur. It's an aortic regurgitation murmur, which ends up being very important in this patient's diagnosis later on. But the decrescendo was referring to the heart sound that I was hearing. So it gets starts off loud and gets softer, versus a crescendo murmur starts off quiet and then gets louder. Was that helpful? I hope so. Let me know if not, and I can explain more. Okay, perfect. Okay, so labs for this patient. So we can start off with the fishbone. Oh no, something got moved over. That's okay. So his white blood cell count was, so actually let's start with his CMP. So his CMP was for the most part within normal limits. His potassium was within normal limits, which is something we always like to check for in heart failure. And then his CBC was also within normal limits. So his hemoglobin was fine, his hematocrit was fine, and even though it was a little bit on the lower end, it was stable. I wasn't concerned that he was actively bleeding out. And then also his white blood cell count was within normal limits. Other notable labs for him, his troponin, which is a enzyme that we look for out of the heart that measures cardiac strain, was elevated. So each hospital has sort of its own cutoff based off of the troponin they use. Our cutoff is anything greater than 0.02 is an elevation. And so his first troponin in our ED was 0.04. So that showed me that he had strain on his heart. His BNP, do people know what a BNP is? This is what we look for when assessing for heart failure or anything that is putting, that is like stretching out the heart. And his BNP was elevated. For his ABG, an arterial blood gas, this showed that he had a pH 7.55. Does anyone happen to know what a normal pH is, and like hopefully what you or I have if we're not sick? Yes, yep, 7.35 to 7.45. Awesome. His O2, so the O2 going through his blood was 30. That is very, very low, like very low. So that was concerning for me. His CO2 was 57. So does anyone happen to know what normal CO2 level should be? Normally a little bit lower than that. I would expect to see a CO2 level of in an arterial blood gas of like in the 30s to 40s range at the highest. And then the last value isn't really relevant to this discussion. So he actually had blood cultures that come back. No, great job though. Thank you for mentioning that. He had blood cultures that had come back from his previous emergency department visit that actually were positive for Staph aureus and E. faecalis. So not really, that's bad that he had positive blood culture, especially the E. faecalis, and we'll talk more about the Staph aureus positive blood culture. And this grew out in 2 separate bottles. So he had 2 blood cultures drawn on his original ED visit. And then his EKG showed that he had a slightly prolonged QT at 494. We normally like to see QTs a little bit less than like between 450 and 475 is when you would start to get worried about giving people prolonged drugs that prolong the QT. And there are a lot of them, such as antiemetics, like Zofran is one that we commonly use. So something just to keep your eye on in patients in the emergency department when you get an EKG. Okay. So this was not his chest x-ray, but this is pretty similar to what his chest x-ray looked like. So does anyone want to take a shot at what could be going on here? When I was a student, I hated reading x-rays, but people can write in the chat what they're thinking while I sort of go through the basics. So if we look at his airway, he has this person has a good patent airway. It's midline, it's not shifted to one side or the other. Then from there, we want to look at the bone structure. So if we look, we see lots of ribs, which is a good sign. That shows that the person has taken a nice deep breath. And then from there, we want to look at the cardiac silhouette. So this cardiac silhouette is not bigger. So you want to make sure that the heart isn't enlarged. And so this cardiac silhouette is within normal limits. Next, you want to look at the diaphragm and make sure that the diaphragm contours are clear and that there's no sort of schmutz around the diaphragm. So the claustrophrenic angles, those look good in this person. And then E is for everything else. And so if you look over on the left side of this picture, excuse me, the person's right side, you see a little bit of consolidation, which is concerning for pneumonia. So this is pretty similar to what his chest x-ray looks like. Yeah. And the lower lobe, good. And the right lower lobe, yep, perfect, because it's flipped. It's the pitch, imagine the picture going forward. Yeah, exactly. So the reason that the right side is darker, I would say it's probably just the x-ray probably should have been adjusted a little bit. It looks like it's a little bit overexposed. And so when we're on our computer systems, what we can do is like either lighten or darken the x-ray to fix for that. And I just didn't have his x-ray up, but this should have been fixed by the radiologist or by the radiology tech. Also, he could have been this person could have been slightly rotated by looking at the collarbones. So I would say that's why, just a little bit of overexposure. Okay, so there's a lot going on in this patient, but we have some things. We know that this patient has been having fevers, chills, shortness of breath, continues to have that in the emergency department. The fever and the shortness of breath is working hard to breathe. And then also the x-ray looks like there may be a little bit of a pneumonia. So, and the person has a history of IV drug use. So what types of things could we be thinking of based off of this patient's story and their physical exam? You can say really anything. Like, it's good to have a nice broad differential diagnosis. So, okay, yep. Okay, good. Some type of an infection, great. So whether that be a blood infection, TB, yep, always good to keep that in your differential. Heart failure or infection due to extended IV drug use, yep, absolutely. And when we say infection, this person has they have a fever, they have a high heart rate, they have a high respiratory rate. Is there a specific term we can think of to be more specific about the manifestation of this patient's infection? The word starts with an S and ends with an S. It's like a read my mind. Sepsis is definitely on the differential as well. Great. Really good job keeping a broad differential diagnosis, everyone. Okay, so the things that I was thinking of when I was going through my original differential diagnosis after, can I repeat that? Sepsis? Yeah, I'll write it in the chat. Yeah. Okay. Oh. So let's see. Okay. So great job. So yeah, I was thinking of a bacterial endocarditis, sort of thinking about the patient using drugs for a long time, and having a fever, having chills, and having new onset heart failure. That was something I was definitely thinking of. As someone said, heart failure is definitely going to be on the differential, not just new onset heart failure, but also an exacerbation of his heart failure, since he felt well enough to leave the emergency department a few days prior, but then ended up coming back Sepsis secondary to pneumonia was also on my differential. And then lastly, a COPD exacerbation. So someone mentioned asking about the patient's social history, like alcohol use, smoking. He was a smoker as well. And since he was so short of breath, that was something I was also thinking of. Okay. So the assessment and plan. This is a 51-year-old male who uses IV drugs daily, and he's presenting with 4 days of fevers, chills, shortness of breath, and this is all in the setting of newly diagnosed heart failure. His vitals were concerning for his tachycardia, so his heart was beating really, really fast, his tachypnea, he was breathing really fast despite already being on oxygen, and having a fever, being febrile. His labs were notable for an elevated troponin and BNP, so those enzymes that show stress on the heart, having an arterial pH of 7.55 and a really low oxygen, which shows us that, and a very high CO2, which shows us that he was not properly blowing off air or getting blowing off CO2 or getting oxygen into his lungs. And he had previously positive blood cultures for Staph aureus and E. faecalis. So based off of all of that, his presentation was most concerning for endocarditis for me. So the things that we did in the emergency department, the first thing is that we ordered a stat transthoracic echocardiogram. So even though we put an ultrasound on his heart at the bedside, we wanted an official read by a radiologist just to make sure we weren't missing anything. We ordered 3 sets of blood cultures, all from different sites. This is very important. 3 sets of blood cultures, all from different sites in endocarditis. We started the patient on broad spectrum antibiotics, and this patient was subsequently admitted to the hospital for IV antibiotics. Okay, any questions before we start to get into the pathology? Yes, what types of IV drugs he used. So he told me that he used heroin daily, and then sometimes he would mix his heroin and crack cocaine together. But then specifically when we did his drug screen, we found other things in his drug screen. And I think that's because, you know, even when people sometimes, you'll see in the emergency department, we see this a lot. Sometimes people think that they're buying one thing, but then that specific drug can have other additives in it, unfortunately. And so, yeah. Let's see, can bacterial endocarditis be caused by other things? Yeah, so that's a great question. We're going to get to that. So the big overarching umbrella of this is endocarditis. There is non-infective endocarditis and then infective endocarditis. With this patient, we're specifically talking about infective endocarditis and even more specifically bacterial infective endocarditis, but people can get viral infective endocarditis, fungal infective endocarditis. I've only seen that in like really sick HIV or AIDS patients, but you can definitely see that. Does that answer your question? But we do see it in patients who use IV drugs if they are not using clean needles. Okay, awesome. Okay, so infective endocarditis. So what is it? So endocarditis as a whole is going to be an inflammation of the endothelium of the heart, the heart valves, or both. Who gets it? So people who are most at risk have a disease or a damaged heart. So these can be people who have congenital heart disease, people who have rheumatic heart disease from having strep in the past, or people who have other congenital problems like a bicuspid aortic valve, for example. Other risk factors include IV drug use, immunocompromised states such as HIV, AIDS, TB, and then poor oral hygiene. And so we'll see people who have teeth that are like literally running out of their mouths, and they have an infection that spread through their bloodstreams and cause endocarditis, which is quite scary. And then what part of the heart is usually affected by endocarditis? So where do you tend to see it? So another really important thing to remember. So even though the mitral valve is the most commonly affected valve overall in endocarditis, what we'll see is that the tricuspid valve is most commonly infected in IV drug use. But overall, the most effective valve is the mitral valve. And I remember when I was a student, I was trying to remember why this was. And basically, it's just about whether or not the person who is having the infection has seeding coming from the right side of their heart. Let's see, can this cause degradation of the strength or integrity of the heart valves? Yes, absolutely. And so we'll see that sometimes people who get endocarditis end up growing these big vegetations, basically just like clumps on their valves. And that definitely really messes up the strength and the integrity of the valves, which is why we can hear heart murmurs on people with endocarditis. Great question. Oops. Okay. All right. So in normal valve endothelium, our hearts are pretty strong at baseline. Like normal healthy hearts without any congenital problems are pretty strong at baseline. In a normal valve endothelium, as well as heart endothelium, there's normally a resistance to colonization and infection of due to circulating bacteria. So even though a pretty healthy person could get a blood infection, they likely wouldn't get endocarditis if they had a strong heart, at least the first time. However, micro trauma that can be due to turbulent flow for a long period of time, chronic heart disease, and previous bouts of infective endocarditis, damages and weakens the endothelium and can ultimately cause formation of thrombi, which are basically fibrin and platelets sort of together. And these thrombi can be seeded by bacteria, fungi, and viruses. So there's a pretty good graphic here. So if we look at the top, we know that healthy individuals have normal endothelium, so that's not going to get infected at all. This like looks healthy, you know, everything's just flowing right over it, and that's the ideal goal. And people with rheumatic heart disease or congenital valve disease, such as that bicuspid aortic valve, we start to see that there's a damaged endothelium and the bacteria, like basically we can get trapping of the bacteria or the fungi or the viruses within these areas of the damaged endothelium once a thrombus forms. And then same idea so that's for damaged endothelium, and then same idea if someone uses IV drugs a lot, has really bad atherosclerosis or sepsis, when their endothelium get inflamed, they're more likely to grow these thrombi of the fibrin and platelets, and then there's the seeding process that happens. As you can see, like those like circular things are the seeding. And then at the bottom, they talk about prosthetic valves, but we won't get into that today. Any questions on that? So basically, if someone has a nice, healthy heart, nice, healthy valves, you sort of expect if any infection were to get in there, it would sort of just flow right over it. But as soon as you have a damaged endothelium or an inflamed endothelium, a person's more likely to have thrombi formation. And then in that thrombi formation, there's seeding that occurs. All right, so diagnosis and evaluation of endocarditis. So in people with endocarditis, there are things that get tested on a lot that you may or may not see in a person. So looking at, I don't know if anyone has ever seen Med Comic before, but I use this all the time in medical school and when I was a pre-med to remember things. But in a person with endocarditis, you would expect to see a lot of different manifestations of the endocarditis. And so what can happen is that a person can get raw spots of the retina, which are basically just areas of the retina where they're like seeding of the bacteria. They can also get dermatologic manifestations such as Janeway lesions and Osler's nodes, and we'll get more into that later, as well as splinter hemorrhages, which are seen on the nails. As I mentioned before in the middle part with the heart, the mitral valve is most frequently involved in endocarditis, but the tricuspid valve is most associated with IV drug use. And then it's like, well, okay, so we have all of this, but how do we actually diagnose endocarditis? So there's something called the Duke criteria for diagnosis, which I'm very biased towards because I went to Duke University as an undergrad. So there are to be diagnosed with endocarditis, a person either needs to have 2 major Duke criteria, 1 major or 3 minor, 1 major and 3 minor Duke criteria, or 5 minor Duke criteria. And so they have examples of the major Duke criteria here. So 2 positive blood cultures, a positive echo, and a regurgitant murmur. And then you can also see the minor criteria, someone with a predisposing condition such as the heart disease that we talked about, someone with fever, any type of immunological signs, 1 positive blood culture, and then a positive echo that doesn't meet major criteria. And I'll go to the next slide, which has a little bit more info. So this is something that if you're all interested, that you can look over sort of in your spare time. But when we look at blood cultures, we expect to see certain things be positive for infective endocarditis. So typical microorganisms that we would expect to see in a positive blood culture would be like Staph aureus or Strep viridans or Strep bovis. And then let's see, for the echocardiogram, so 1, 2, 3, the bullet point number 3, the echocardiogram that's positive for infective endocarditis, that is something that we really want to see. And normally you would do the echo of on the chest and not the one that goes down the esophagus. And then you would also expect to hear a new valvular regurgitation, which is what I heard when I talked about that murmur I heard on him. He had an aortic regurgitation, which was new and had never been documented. So he had 2 major criteria, but he also had some of the minor criteria, such as IV drug use. He had a fever. That was it. He didn't have any of the other immunological phenomena. Yeah. Any questions so far? If I'm going too fast, please let me know.
What's aortic regurgitation?
Sure. So that is going to be so we have our heart, and as our heart beats, we expect blood to flow in a certain direction through the heart, right? And so when the problem with aortic regurgitation or any type of a murmur, like a regurgitation murmur, so tricuspid regurgitation, mitral regurgitation, instead of the blood moving forward like it should to, circulate through the body, circulate through the lungs as it's supposed to, what you have is that some blood like basically backflows. And so instead of only going forward, you have some blood that a lot of it goes forward, but some of it also backflows. And so for him, he was having backflow through his aorta. So where his aortic valve is, it was supposed to be going through the aortic outflow tract, but it was flowing back into his left ventricle. Did that answer your question?
Absolutely, thank you.
Okay. Let's see. Okay. So diagnosis and evaluation of someone with endocarditis. So I think that this is sort of good practice to do on anyone who seems to be septic and is having chest pain or has new onset heart failure. So things I would always want to get will be basic labs. So a complete blood count and something that you could see, we didn't see it in Mr. M, but something that you could see in a patient is having an elevated white blood cell count. You can also get a complete metabolic panel, which we did get in him, but I wouldn't expect to see any specific abnormalities. A urinalysis is always a good test to get. Aside from doing a drug screen of someone, isn't really sure what they took, which can always be helpful. A urinalysis may also show hematuria in infective endocarditis, because people can have the seeding that I talked about. Basically, the bacteria can spread to other parts of the body and affect the kidneys, and through affecting the kidneys, they may have blood in their urine. And then we would look at inflammatory markers as well. There are lots of inflammatory markers that we use as physicians, and sort of follow them to make sure a patient's getting better. Two of them are ESR and CRP, so C-reactive protein, and then the erythrocyte set rate. And then also a lactic acid is something else you could get in someone who you're concerned about sepsis in. And then lastly, because he was having this chest pain, I knew he had just been diagnosed with heart failure a few days ago. I got the troponin and the BNP. Imaging that I want to get, if you're concerned about endocarditis, an echocardiogram is the most important test to get as soon as possible, because if you see some type of a vegetation on the valve, that would sort of determine whether or not that person needed to go to surgery as soon as possible or not. And then also a chest x-ray. And so that can be useful to evaluate for any heart enlargement due to the new onset heart failure. And then adjunct diagnoses, I always like to get an EKG on patients who are having heart problems, just because you never know what you'll find, such as that prolonged QT that we talked about earlier, or even sometimes you can see that people who have endocarditis have heart attacks. And so you'll want to make sure that there's no evidence of a heart attack on EKG. And then treatment. So for the treatment, there are lots of different ways to treat bacterial endocarditis based off of if the patient has been treated before, if the patient has other problems going on. But the way that we decided to treat him, so the first drug combination, ampicillin, sulbactam, Unison, and gentamicin. We don't really use Unison at my hospital, so we didn't use that. But the second point, the amoxicillin, clav, and gentamicin, we use because we just happen to have that on formulation at my hospital, and it was available quickly. And then we also added on vancomycin for any MRSA coverage, just because we weren't really sure if he had been exposed to MRSA and if he had risk factors or not for having MRSA, but based off of his drug use, we wanted to make sure to cover for MRSA. So we started him on very broad spectrum antibiotics. And then let's see. Okay. So when I was talking about the echocardiogram, so if you look to where this arrow's pointing, it's pointing to the aortic valve. And so normally I would expect that when someone's heart is beating, the blood's going from the LV, so the left ventricle, past the aortic valve into the aortic outflow tract. However, he had a very large vegetation on his aortic valve, which was causing his valve to not work. So the valve should open and then it should close. But because of the pressure in his heart and his valves being like a little bit leaky because of the vegetation on it, he would pump blood from the left ventricle to his aortic outflow tract, but then he would also have some blood that will flow right back into the left ventricle, which was causing his heart failure. Basically, he was having too much blood in his left ventricle and it's being stretched out, and his walls were getting weak. But this isn't, it's hard to see it. It's easier to see on videos in real time, but if you sort of look in between the LA and the LV, that would be a normal valve, whereas there's like a little Goomba on the aortic valve, and that was his vegetation. Any questions on that? And once again, that vegetation is formed because there's that thrombi that forms to begin with, and then it was seeded by bacteria, and it basically got bigger and bigger and bigger. And then as I promised with the skin findings, these are things that everyone loves to test on, and it's really good to have pictures of these in your head if you ever do see a patient with endocarditis. So there are 3 commonly tested skin findings and things that you should always look for in a patient with infective endocarditis. So the first thing is going to be the splinter hemorrhages. So on the nail beds, normally on the distal end, so like towards the long part of the fingernail or the part of the fingernail that goes past the nail bed, you can see sort of little lines, which are basically emboli of the bacteria. And this is a pretty good picture. I've seen a few splinter hemorrhages in real life, and they look like this, just like little small dark lines on the distal end of the fingernail. Osler nodes. So when looking at the middle picture, Osler nodes, that looks scary, right? It looks painful. It looks just like really bad. So Osler nodes are these painful lesions that form on the hands and the feet. And then lastly, Janeway lesions are smaller. They can be, so they have different sizes. So they can be either papules, so little, or macules, which are little raised areas. And so they can be either papules, macules, and you can see basically them on either the hands or the feet, and these are painless lesions that occur on basically the same spot. You would see them on the palms of the hands and the feet, as well as Osler nodes. But remembering that Osler nodes are painful and Janeway lesions are painless, and then splinter hemorrhages are on the fingernails. Any questions? And then finally, when we think about the complications of infective endocarditis, heart failure is going to be the most common cause of death. And so this person who came in did have new onset heart failure. So he probably had endocarditis for quite a while before coming in. He sort of just got to the point where it was so bad. But this is going to be the most cause of death when people's hearts just aren't pumping blood effectively enough. It will cause death at some point. Other things that you may see, stroke. So sort of those emboli can go to the brain and cause a stroke. You can see septic pulmonary embolism. So that's when people get blood clots in the vessels of their lungs. Other things, blindness from those Roth spots. So from the spots that end up in the eyes, on the retina, myocardial infarction, so a heart attack, which is why you want to get an EKG. The renal infarction, so when the bacteria sees the other parts of the body, it can cause a renal infarction, or basically death of the kidney, which is why you can see blood in the urine. And then lastly, a spinal abscess is something to just keep in mind if someone uses any form of IV drugs, or uses IV drugs at baseline, but especially if they have endocarditis. And my closing thought for you is that if you see endocarditis in real life, it actually can look a little bit like lasagna. And so is it lasagna or is it endocarditis?
I'm eating.
Sorry about that. I hope you're not eating lasagna. Okay, and these are my sources. Really awesome job. Let's see, is there any permanent scarring from those lesions and nodes? That is a really good question. I actually have no idea. I have not, unfortunately, seen any patient with endocarditis live long enough to see the permanent sequelae of that. But I don't know. That's a great question. I'll have to look that up.
So is endocarditis usually quickly followed by death, if not, intervened with?
If not intervened upon, I can speak specifically to endocarditis from people who use IV drugs. Normally, surgeons will not do any form of intervention unless the person has stopped IV drugs for a certain number of weeks to months. And for a lot of people, addiction is a difficult thing to, their addiction doesn't allow them to stop. And so a lot of people do end up dying, but you can see non-infective endocarditis, and people tend to do a lot better with that. Did that answer your question? Do you have any other questions about that?
No, thank you.
Okay, great. So MRSA, I'll go back to the assessment plan slide while I talk about, is that okay? Becca, if I go back to the assessment plan slide. I'll talk about MRSA once I get there. Here we go. So MRSA is basically methicillin resistant Staph aureus. And so basically it is based off of what the reason MRSA is important is because the way that you target antibiotics towards it is going to be different because it's resistant to a certain class of antibiotics. His blood cultures did not grow out MRSA, like the methicillin resistant Staph aureus, but it did grow out Staph aureus. And just with his past medical history of using IV drugs and having endocarditis for an unknown period of time, we wanted to treat him for that. But normally, a lot of times if someone gets blood cultures or even if they get a nasal swab, it's easy to see if someone has been colonized with MRSA. It spreads really quickly on wrestling teams, actually. That's one thing I learned during medical school, just in case you're wondering. Was that enough time for the assessment and plans slide, Josh? Or do you want me to leave it up for a little bit longer? Okay. So whenever you all get the chance, filling out the quiz to the best of your ability. Some like takeaways: remembering 3 blood cultures are really important. The most commonly effective valve is going to be the mitral valve. And then remembering the skin findings we can see. And then also remembering the importance of starting someone on IV antibiotics and admitting them to the hospital. So hopefully that's a helpful recap.